All right. Good morning, everybody. I'm Vincent Atchity, CEO of Mental Health Colorado, and this is our monthly reports and updates from Colorado allies and partners who are working to disentangle mental health and criminal justice, which is a key advocacy area of interest for us here at Mental Health Colorado. And we're very appreciative of the work that all of you do to redirect people with healthcare needs toward healthcare and appropriate supports in the community. Each month on this Thursday of the month, we have some partner from around the state presenting on their work. We try and keep the meeting compact so that it's not a giant burden on your busy schedules. And we usually allow the presenting partner about 30 minutes to talk about the work, and then we've got 10 to 15 minutes for questions, any updates from additional partners on the call, and then we'll wrap promptly by 12:40, by a quarter past at the latest. So without any further prelude, I just want to observe that today we had scheduled Sheriff Jamie Fitzsimons from Summit County, who very unfortunately is not well today, but happily has sent his lieutenant, Daric Gutzwiller, and apologies if I'm pronouncing your last name incorrectly, who will present on the SMART program in Summit County and the great work that you're doing up there. And so with that, Lieutenant, I'll hand it over to you, and you can share your work, and folks can ask questions at the end or put questions in the chat, and I will help moderate at the end of your presentation.
Awesome. Thank you, Vincent. I see a lot of familiar names on here from some of my peers. As Vincent mentioned, I'm Lieutenant Daric Gutzwiller, or Guts. I'm here today for Sheriff Jamie Fitzsimons. I can give you guys a brief overview of our program and some of the work that we're doing. Can I share my screen? Can you guys see that okay? Is my screen coming across?
Yes.
Okay, perfect.
Yeah, sorry.
Well, cool. Yeah, I've been with the Summit County Sheriff's Office for about 20 years, mostly in the patrol section and investigations. About at my front door, and it was Sheriff Jamie Fitzsimons. And he had some very troubling news to tell me that my father had committed suicide. And I had been on hundreds of suicide scenes, but I was very ill-equipped to handle that when it was so close to home for me. And something that kind of came from that or through that, all of my peers really wrapped me in a lot of services and support shortly thereafter. I had an army of people in my corner as I kind of worked through some things myself regarding his loss. And I kind of got to wondering after that, you know, most people that go through trauma like that, or those kind of traumatic things, or grief and loss, they really don't have those kind of support networks in place. And so shortly thereafter, Sheriff Fitzsimons had approached me about some ideas that he had. We were applying for some grants, and he kind of gave me free rein to go throughout the state and go to many different programs that had already existed, and kind of take parts and pieces from each of those programs to build something that would work here in Summit County. And that's kind of the inception of our program, or where it came from. That was 3 years ago. And what we came up with after moving around and doing some research was a co-responder program with intensive case management support. We respond anywhere within Summit County for mental health calls that have a public safety component. That includes 5 municipal jurisdictions. Locally, we have some MOUs so that we can do that. And we will respond face-to-face with a person in crisis to provide assessments, stabilization. We use least restrictive means, so we will try to stabilize people over hospitalization when possible. And we look to divert costly, we try to make direct connections to save costs to both the community and to the person that might be experiencing a mental health issue. Our model uses co-responder, just to give a better explanation of what that is. That's where a police officer is paired with a mental health clinician. They respond to calls for service, typically people that are homicidal or suicidal. And the way that this team works is the police officer, being a public safety expert, goes in and makes the scene safe or creates a safe space where we can introduce a clinician. And the master's level mental health clinician can then work with that client face to face right where this crisis is occurring in a safe and controlled manner, or as safe as you can make a scene like that. We respond in unmarked vehicles. Our officers are plain clothes. I've been on several calls where the client is more attuned to speak with the police officer than the clinician. It's kind of a partnership so that people can best be reached and preserve their dignity without escalating the situation in a way that may be negative for the client. All of my guys have specialized training in mental health. We do cross training back and forth, so each is very well aware of the roles of the other. And then we also work to let other resources go from these scenes whenever we don't need them. So instead of having a fire truck, an ambulance, 3 cops show up, my team can show up covertly. And if we don't need additional resources, we'll just divert them so they can go right back to the job that they do every day. I mentioned we have intensive case management. So after a person may be experiencing a crisis event, case managers work to help that person get continued treatment, mitigate barriers to treatment, and set goals with the client. There is no set time for case management. This could be days, weeks, months. We have some clients that have been with us for 2 years now. It's very difficult for a person to navigate insurance networks and court systems regularly. Now, try to imagine a person that has severe schizophrenia, try to navigate these kind of things. Case managers will help with navigation work. And it's pretty interesting, I think. I mentioned I've been in law enforcement here for 20 years. And there are some people that I've dealt with for 20 years straight here that, you know, I honestly got tired of putting them in a cage over and over again for crimes they may have committed. And it's awesome to see case management work with somebody and you start seeing these pieces chip away. And so maybe they were having trouble getting their VITA statistics registered birth certificate because of the government red tape. Case managers will work with them to get that. Then they can get a driver's license. Then they can get the person insurance, then psychiatry, then medication. It's awesome to see this transformation over a very short period of time. And these people then become an awesome member of the community. They've made some great recoveries. It really isn't anything that happens overnight. It does take patience, and not every single client in case management is a success story like that, but a good number of people that I've worked with for 20 years have really turned their lives around. And that's just pretty amazing to me to watch that. We also work with populations that experience severe and persistent mental illness at many different levels. We also work with high utilizers. Those are clients that may frequently contact law enforcement or have law enforcement contacted on them. Specifically, one person that we had 600 calls in 1 year, either from him or for him. And we'll directly connect with that person. We create a relationship where we will call them every day if they're not calling us every day, and we help them navigate life. It's very interesting in those respects to watch the recidivism of those individuals just drop to zero when they have intensive case management in their life. I mentioned severe and persistent mental illness. We also do some work with people in our community that might not qualify for programs. We have a juvenile that has intermittent explosive disorder. He tried to stab one of our deputies. He caused $20,000 worth of damage in a very short period of time. And you guys can probably imagine that 4-H is not going to allow him to participate in programs. So our team offers some mentoring opportunities for people with severe and persistent mental illness that might not have access to other programs, to engage them, because we know at some point in the future we'll be working with that individual again, or they may have an episode and we're going to respond, and we want them to be familiar with us. So we do some mentoring opportunities with certain people in our population that experience severe and persistent mental illness. We do some fun projects with them, and we always end it with a law enforcement lesson to try to teach them, this is what you would do on a traffic stop, or this is the way to be a good witness and call 911. And it creates this two-way street, this engagement that we find very, very beneficial in our community. There's really not a wrong door to getting people into services. The way that a regular call breaks down for us, I guess typically might be that we respond to a scene where we believe there's a mental health component to a public safety call. Most of our calls come in through 911 or Colorado Crisis Services, the hotline in the state. And the first thing we're going to work to do is make the scene safe and de-escalate the situation in a safe way for everyone. From there, we're going to assess the individual and make a determination on next steps. We're going to look to divert the person from costlier services like going to the ER. We don't have a walk-in center in Summit County, so every single person that is experiencing a mental health episode prior to the SMART team would just get taken to the ER, and they don't offer mental health services while they're in the ER. They're just looking for bed space elsewhere in the state. So this is a person that we've just taken, strapped to a bed for 3 days, forced medicated against their will while we're looking for bed space for them. And so right after their crisis, they're hit with a $30,000 hospital bill. And you can see how that's not necessarily beneficial for the client if they were already suffering from high stress and anxiety. So instead of taking them to the hospital, we can do direct placement anywhere in the state. We have access to the bed registry. And right from a person's house, if they need a higher level of care, we can see every bed in the state and then find a program or treatments that work best for them. And then we'll take them directly to those places. And we will respond and pick them up when they're done with services and bring them back to our community while we do a reentry plan. This direct connection saves the hospital time and energy. They typically deal with more physical injuries, and they don't really care for people that might be suffering from psychiatric disturbances to be screaming and hollering in their ED. And it gets them directly into treatment immediately instead of having that gap. We work to coordinate with, I'm sorry, one sec. Yeah, we'll work with different community partners and try to set up a reentry plan that makes sense, connecting people to care when they come back into our community. And one method that we use that kind of works with this coordination piece and with the diverting from costlier services, our team buys out 2 appointments every day of the year. And I mentioned stabilization. What that looks like is we may be able to respond to a scene. A person is somewhat suicidal or having suicidal ideation. We're able to complete a safety plan with that person. And that might look like a lethal means restriction and a written safety plan, but we may also take them over to their mom's house for the night. And because we have those crisis slots, those appointments, instead of taking a guy to the ER for the night where he's held on an involuntary commitment and in a day or two later he can get into services, we can stabilize a person at their family's house for the evening, and then first thing in the morning we have these appointments waiting for them to directly connect them, and these are free appointments to the client. They receive 5 free crisis stabilization appointments with the intention of then transferring the person to ongoing services with a local care provider, such as a therapist here in our community. We collaborate with over 100 different community partners. Once a week, we have a community partner come to our office and they complete a presentation for us and we complete a presentation for them. And we build these mutually beneficial relationships that we can leverage at the appropriate time that can best help a client. And it's not just a one and done kind of thing. They don't just come by one time. We know about their program. We have ongoing relationships with each of these community partners. And I think this model specifically, it probably makes sense for us because we're in a smaller community. This may not work for everyone, but this is something that we found very beneficial locally for our program specifically. Again, I mentioned cross training. All of my deputies receive specialized mental health training. All of my clinicians receive law enforcement training. And we work to build a specialized unit that can best serve our populations. We'll, through case management, a lot of times when people are experiencing different barriers to treatment, we have to come up with some creative solutions. My case managers will go pick somebody up and take them to their appointment or help them set up telehealth if they're not computer savvy. We'll pick up medications for people in our community and drop them off in containers so that they know to take their medication each day. We work with many different local doctors' offices and MAT centers, whatever it is that a client is experiencing as a barrier. We kind of have some free reign from our sheriff to just tackle those problems and do problem solving that works best for that client. There's not a lot of parameters outside of ethical parameters of what we can and will do. We'll go to great lengths to get people the help that they need. So some of the roles, the sworn law enforcement officer is going to de-escalate the situation as soon as he comes into it and make some determinations on whether the scene is safe or he will make it safe. They coordinate with other first responders as far as responses and when other first responders can be released. If they identify potential criminal concerns, we do not complete investigations, criminal investigations. So we may let another law enforcement agency know about those factors that we've seen, but we don't investigate crimes and we don't really arrest people. I think we've had 1 arrest in 3 years. And they complete reports. There's this kind of odd thing going on with a law enforcement agency who is taken on a role of a community mental health center. We actively employ our clinicians and our case managers here in-house at the sheriff's office. But that kind of puts us in this weird position where there's Open Records Act. It's a law in Colorado that says we have to release information to anyone who wants it. And there's protected health information that we wouldn't release to just anyone or can't release to just anyone. So the way that we have tackled this, because we have these 2 conflicting items in house, Our law enforcement officers still complete a law enforcement report. It's a very basic report that just says, hey, at this date and this time, we responded to this place, we contacted this person, and we completed an assessment. That assessment showed the following, and then we'll give an outcome. On the backside, we went to our chief judge, and we were able to have a secondary record keeping system. So clinical notes and reports and things of those natures, our chief judge has protected those documents. Outside of a subpoena, those records cannot be released, and they're protected. So that's kind of how the law enforcement side balances with the clinical side. A ton of our calls, there's other legal issues going on, and that officer can help someone that might be being illegally evicted by telling them about their rights or answer questions about law enforcement. We make sure that the law enforcement officers in charge of safely transporting and taking people into custody whenever we have to place an involuntary custody hold. I do criminal diversion work. In certain cases, not like persons crimes, but let me just give an example. We had a person that broke into a vehicle up here and stole a pair of socks prior to our team's inception. That person spent 2 years in jail because breaking into a car and committing a crime therein is a felony. And this was a person who clearly did this because of mental health concerns. That person then got placed in a system within the state where he gets evaluated for competency, and then a restoration process after that. So 2 years for stealing a pair of socks out of a car. So the diversion work that I do, one of our partners is with the district attorney's office. If I see a case, and I review every case that comes through our jurisdiction, if I see a case that I think fits for mental health diversion, it was a crime committed because of mental health concerns, I'll work with either the district attorney in the courts to get them into programs that might better serve them, or completely divert the case from entering into the criminal justice system. Or finally, I'll ask for sentencing enhancements. That's just sentencing that makes sense. Instead of going to jail, the courts may impose that the person does outpatient treatment, 20 sessions. And that way we are really kind of helping the underlying issue that may have been the catalyst or cause of criminal activity. Oops. Clinicians are licensed mental health professionals of a master's level. They are the mental health expert on our team. They work very closely with the deputy. And again, this is a partnership. They, after completing an assessment, they collaborate together to come up with next steps. They are very well versed with all of the facilities and options available to them, and they try to use the least restrictive means to get a person to care when they need it. They coordinate with all other first responders to help do problem solving. They work to provide psychoeducation whenever that's the appropriate route, and they try to engage people where they're at and break down stigma so that people are willing to engage themselves in treatment. The clinicians on our team act for advocates for the clients and help them to best meet their needs. They can provide direct placement and referrals to programs and resources that are available to clients. They do clinical documentation, and we have a clinical program manager who oversees the clinical side of our house, kind of a professional in that field. They debrief all calls and coordinate with that person to make sure that we're providing the highest level of care possible. Case managers are experts in knowing which services and programs would best help someone, and sitting down and talking with someone for just a short period of time, they can probably come up with a list of 3 or 4 people that will work with their insurance, that fit their personality, that offer the services they need. And then we can directly connect people to services that would best fit and work for them. We will work with clients who, it's very hard to work on your mental health whenever you're hungry or you don't have a place to stay, kind of the Maslow's hierarchy of needs. If we can't fix some of the other problems that also exist, how can we hope to have a person working on their mental health? So they'll work with, again, partners in our community to try to help people through these difficult situations so that they can be in a better place to work on their mental health. Our case managers each continually reach out to certain high utilizers that they have on their caseload to check in with them. We're constantly monitoring their state of mental health while we're also constantly being a support network for them. Case managers can also divert crisis before it starts. So if somebody is having a bad day and they're a high utilizer of ours, before they go into crisis, they'll call our team and we can go there and help put some supports back in place and maybe redirect this person or get them into some level of treatment that could be helpful to them. And then they don't go into a full-blown crisis. Case managers actively work to maintain those relationships with all of the community partners that we have, and often going to their offices or having people over to ours creates these mutually beneficial relationships that we can leverage at the right time. So if a doctor in our community needs to place someone on a mental health hold, I wouldn't expect them to have to knock a person down in their lobby and throw handcuffs on them. Some of the higher level stuff like that, or arrange safe transport to somebody to Grand Junction. We'll if a situation like that were to occur, we can use our law enforcement partnership with them to safely take a person into custody and safely transport them to wherever they need to go. And vice versa, if I need an appointment tomorrow for a person that may have a medical condition, I can call that doctor's office and they will reciprocate and help us to best serve that person. Our case management section works to directly place people remotely. They may not be at the scene, but they will do all of the background work to get somebody placed in a facility. Case management is open to friends and family of the client as well. If a family may need family counseling, we can have our case manager work towards those ends. Also advocates for clients. And additionally, they're well-versed in mitigating barriers. So if a person cannot afford therapy, we have a scholarship program locally that we can access and get someone, first of all, the 5 free stabilization appointments, plus another 19 appointments with a therapist and 6 psychiatric appointments for free. So they just know all these different avenues of how to help people, and then they use the appropriate navigation tool to get around barriers to treatment. Typical calls that we would go to might include suicide in progress or suicidal thoughts, self-harm, persons with weapons. I know some programs don't respond to these higher level types of calls, but we do it in a safe and controlled way using the police elements that are with us until we can make the scene safe to do a face-to-face assessment. Every one of my employees is a crisis or hostage negotiator. So we do negotiations for every law enforcement agency in our county. All of my cops are CAT certified, so they do some work around substance abuse. So there's a multitude of calls that we'll go to, as long as there's really the generals, as long as there's a mental health component to it and it's a public safety call, that is something we would respond to with a co-responder. We also have a contract through Rocky Mountain Health Plans. We provide mobile crisis services. Mobile crisis is very similar to co-responder, but it's only a mental health clinician making this contact with the client. Basically, the law enforcement officer would outside. These are lower risk calls. There's a certain set of criteria, and it may be suicidal ideation without a plan and without means. We can just send the clinician in to work with that client. Our clinicians have a, it's kind of like a fob or it's called a panic alarm that they can wear on their person. And if they get into anything where they need law enforcement assistance, they can covertly notify their partner who's waiting in the car in the driveway or right around the corner, hey, I need assistance, and do that in a safe manner without alerting the client. This is a partnership that we also have with Colorado Crisis Services. If Colorado Crisis Services can't stabilize a client on the phone, but they can make a determination that these are lower risk calls, they can activate our team 24/7 through mobile crisis for a mobile crisis response. I talked a little bit about this already. Stabilization is a tool that we have at our disposal to connect people directly to services while still keeping them safe, even though there may be some aspects of suicidality. This is a slide that talks a little bit about stabilization and the kind of cost savings that we see in our community. These are prices local to Summit County, but a regular intervention where someone is taken to the emergency room costs about $35,000. Whereas if we use the stabilization program, we're talking about 1,100, probably closer to $1,000 per event. We stabilize about 80 to 90% of clients in place. Guys, that's about it for an overview of our program. Anytime that any of you are in Summit County and you would like to do a ride along with us, I would happily invite you to swing by and grab a cup of coffee and we can talk. And you could ride with my team if that's something that would interest you. I guess now that we're done with the overview, I'd open it up to any questions or comments, thoughts you guys have.
Thank you so much, Lieutenant. Great presentation and such great work that you're doing. I've got some questions, but anybody else who wants to get started, please go right ahead.
Your team is on call 24/7?
Yeah, that's correct. On calls 24/7, and we are actually in the field 20 hours a day, 7 days a week. Our guys work 10-hour shifts. And then that 4-hour period that we don't have a team on, there's also on-call services during those.
There's a question in the chat asking, what did you say the average cost for the stabilization program response was? There you go. Yeah,
so when we break this down, the biggest portion of this being placement, is about $35,000 a crisis. If there's criminal justice entry, this is the lowest level of offense. This goes up exponentially. So for typical crisis, this is the cost. And this $1,100 is with us using the outpatient, those outpatient sessions that we pay for. And that's $1,100 for 6 outpatient appointments, direct connection.
And Lieutenant, does that $5,000 lowest level criminal justice system cost, does that represent the cost of jail stay, or what does that include? What's included in that?
So whenever we look at what it actually costs the criminal justice system, you got to look at a bunch of different things, like what's it cost to have a jury selection or bring it before the judge, to have an attorney. This is not anything to do with jail. This is outside of the jail system completely. Probation, the cost of probation for 2 years. Those are more so what the criminal justice system entry fee is. jails. I know that the typical cost of holding an inmate for a day is around $75 a day. And that is not including things like what we pay staff to be there. That's just the actual room and board is $75 per day they're in custody.
Yeah, this is such a great representation of the cost savings. And, one of the things I'm curious about, because I've been making this argument to county partners to suggest that a lot of the cost of managing a mental health crisis falls on the county and is borne within that county budget. And if more counties around the state and country were to invest in developing your kind of a program, that they would realize all of this kind of cost savings that would more than cover the costs of the program. Is your county doing that kind of explicit cost shifting to support the SMART program?
So it's interesting. Our program is mostly supported by grants, one of which specifically is a taxation that we have on marijuana in our county. That is our primary funding source, and that's what actually pays for our crisis stabilization appointments specifically. So our program costs about $1.9 million a year to run. Our cost savings are estimated to be about $9.8 million. And then we also have this savings that's associated to bringing other first responders back into service or letting them do the job that they're for. So there's like this secondary piece to that as well. But yeah, I think what our county actually pays out of pocket for a year of service with 4 full teams is around $600,000.
I'm just looking forward to the day when there's more of that really explicit cost shifting away from spending on jails and on healthcare in the jail setting, which is all borne by the county, to doing this kind of work.
Truly.
Hang on, let me see if this is a question. No, just more recognition for the great work that you're doing. We've got another couple of minutes here. If there are other questions.
I have a question.
There you go.
Hi there, I'm the chief of Black Hawk, and I see Commander Thornton there. I actually worked with Arvada for 25 years, so I'm very familiar with co-responder. And my question to you is, up here in Black Hawk, we kind of have a unique situation because I only really have 100 residents, but I do have a large mental health issue up here for visitors that come up here, and I believe you maybe run into this as well. So
Absolutely.
How do you handle, how well does this work with the transient population? And I don't mean the homeless population necessarily, but the people that come up to visit and have crises and that type of stuff. How does that work? And because I am very interested in learning more about this for our community, because it's a very different dynamic than just your average residents who are running into issues.
Sure. And being in Summit County, we have Breckenridge, Keystone, A Basin, and Copper. So we have a ton of people that come up from the Front Range. Also a very small standing population and a ton of people that are here to play. The way that we work that is we provide the same level of crisis services for people that are visiting, but then we also do referrals out. So unfortunately, last week, my guys had a hostage negotiation that lasted 6 hours with a police officer who was suicidal in our community. And we were able to eventually talk him out. And so not only do my case managers know about the different resources in our community, they're aware of other programs, other teams throughout the state. And if I need to talk to Carrie in El Paso County because I have a client that fits them, I can certainly give her a call. Or in this case, I knew that this person was kind of within the wheelhouse of Brower Psychological in Denver. So we do these referrals out so that they don't just leave without care after they leave our community. We can connect the dots between here and there the best we can. And some places don't have a lot of services. I mean, there are some rare exceptions where we just can't make that happen, but we try to follow up in every one of those instances with the person's local jurisdiction under continuity of care, and get the person into ongoing services wherever they're geographically located.
Because we run into a problem where we don't necessarily have the resources and the transportation to get to resources. So do you have a facility right there in Breckenridge or close by?
Our nearest facility is in Grand Junction,
Yeah.
or we can go down to the Front Range as well. But yeah, we don't even have a walk-in center here. So again, I think this is kind of different for our community as opposed to others. Our sheriff has allowed us to just do the transport wherever they need to go. We'll separate that team. We'll leave the clinician locally here. They can jump in with another police officer if another call comes out. But the technician in our team will then just do a transport to West Springs or Pueblo right away. And we just find that, you can take somebody to the hospital and you could sit there with them for an hour and a half, and then they can sit there for 6 hours while you're connecting those dots. It's actually just faster for us to take them to the facility where they can get treatment immediately and come back.
So maybe if I could get your phone number, I don't want to take up everybody's time here, but I would certainly like to talk more about the different dynamics of this type of a community versus a residential area. So if I
Absolutely, I'll throw it in the chat.
Thanks.
Great questions. Thank you. Those were a couple of my questions. Another one, Lieutenant, you mentioned how your whole team is trained to do this kind of response. Is that training unique to your program, or is it a collection of different trainings? Is it CIT? Is it other things, or what do you?
Yeah, it's far beyond. My cops are trained in motivational interviewing, and I honestly, what I do is I'm a training fiend. I scour the internet for things that I find interesting and I think could be beneficial for our team. And I kind of feel like co-response right now is the hot commodity, and everybody's very interested in that. But I also know historically that sometimes there may be funding now, but I don't know what's going to happen in 10 or 15 years. So I want this diversity within my team. All of my guys are peer support for our agency. So finding these training opportunities that add value to your team, I really feel like, one, you can go after additional grants and a multitude of different topics, but also you're creating this valuable entity, kind of like the fire department did in the 50s and 60s, right? Buildings stopped burning down because of cinder block and a lot of the construction materials. They did an awesome job transitioning into emergency services where they're not just a one-trick pony putting out fires. They have a large repertoire of things they can respond to. So they'll go to hazmat incidents. And I want to build something that's kind of similar to that, where my guys can do a multitude of things. I don't think the county would ever let us go away because we have our toe in so many different things. And so I'm always looking for good trainings. My guys are going to Force Science Institute later this year. We host a ton of classes up here. We have a crisis negotiations, hostage negotiations class we're hosting next month. I just love training, and I try to keep my guys keep their edge honed.
Well, that's great. Thank you. And I was not aware of that transition in fire department services based on the changing in architecture. That's super interesting as a model for your work. So, hey, we're reaching the end of our time, and we really want to adhere to that promise to release people promptly. Thank you so much for being with us. What a great presentation. This, as all the presentations in this series of meetings are recorded, and they're available on our website. I just plunked that link into the chat a couple of minutes ago. So please have a look there. And Lieutenant Gutzwiller has put his contact information in the chat as well and is evidently willing to chat with anybody further.
Absolutely.
Next month, we're going to be joined by our presenter will be Judge Elizabeth Lath from Denver Courts, who does diversion work, judge-led diversion work. So we look forward to having you join us for that as well. We also welcome any, we've got our programming planned out, I think through August of this year at this point, but are always uncovering future presenters and welcome suggestions from anybody who wants to share their work or know of somebody who's doing good work to disentangle mental health Colorado. We'd love to include them in the series. And with that, you know, we're a 501c3 nonprofit organization wholly focused on mental health advocacy for the state of Colorado. And our work is entirely dependent on philanthropy and the generosity of Coloradans. Thanks for joining us today, and hope to see you again next month.